I use ultrasound in my practice to detect plaque, but there are a lot of questions about it. And today we are going to hear from the expert, Dr. Todd Eldredge, CEO and founder of CardioRisk Labs. If you guys are new here, I am Dr. Lily Johnston. I'm a board certified vascular surgeon, but I specialize in cardiometabolic prevention. So hopefully you will never need me as a surgeon. It is my great pleasure to welcome Dr. Todd Eldredge to the podcast today. Dr. Eldredge, please tell us who you are, what you do.
Well, great. Thanks, Lily. It's a pleasure to be here. I am the founder and the chief scientific officer at CardioRisk Laboratories. I think we're the largest purveyor of carotid intima media thickness testing in the world. We have over 250 million data points in our database currently, and I think we've pioneered the methodology to, if not perfected, to come as close to perfection as we can.
Some of my audience knows what a CIMT is, but some don't, and I get a lot of questions. So can you just walk us through the difference between a carotid duplex, your regular old CIMT, and a CardioRisk CIMT?
Yeah, and that's a great point. I started in this technology. The technology, first of all, was pioneered back in 1986 by Dr. Pignoli out of Italy, a nice guy, a cardiologist. And he discovered that, wow, with ultrasound, he could see these atheromic lesions and thought, wow, this could probably be useful. And it turns out he was very accurate. And then my mentor, Dr. Gene Bond, out of Wake Forest University, who was a pathologist, but got involved. They've got a wonderful ultrasound program there at Wake Forest. Began to study it in earnest, and I got involved with him very early on in that process. But let's talk about the technology. Carotid intima media thickness is a measurement of the inner two layers of the carotid artery, or we can measure it in the femoral arteries. IMT exists in all 100,000 miles of vasculature. Let's call it 60,000 miles of vasculature in the arterials. But it's the inner two layers. So if going from the outside in, we start with the tunica adventitia, which is that tough, sinewy, if you have any deer hunters out there, it's the tough, sinewy material that holds the artery together. Inside of that is a smooth muscle tissue, the tunica media, and just above that is the tunica intima. The intima is inclusive of a one cell thick layer called the endothelium that lines, again, all 100,000 miles of vessels. In fact, it lines every organ in our body. It is by itself the single largest organ in the body. And it's a fascinating organ at that. It does so many miraculous things. We're still learning about it, and it fascinates me every day of my life. But
you mean both?
Because I don't think we completely understand all of the things of the functions that it completes, but it's truly a miraculous organ and just exciting to study. But the intima media, which is what carotid intima media measures, is just what the name suggests. It's going to measure those inner two layers, the intima media, and it measures for thickness. Why? Well, the intima media is where arterial disease begins. It flows through the blood in what's called the lumen, and then these pathogens that carry the potential to create disease, as any pathogen is, right, penetrates the endothelial lining and gets stuck and trapped in the intima. And there it begins its proliferation and it begins to cause trouble. So we measure when we measure the intima media, we're measuring the earliest affirmation of disease formation. If left unchecked, that disease process will move to inflammation in the arterial wall and eventually to the formation of plaque. Plaque is just like a pimple, like an acne pimple. When we were teenagers, we all remember what it's like to get acne. Atherosclerosis, another name could be acne of the arteries. It looks just like acne. It's created the same way when we were teenagers, we could feel an acne lesion forming long before we could see the red splotch in the mirror, right? Because especially like on your nose or someplace, it hurt. And the reason it hurt is that inflammation was causing pressure against the neuron, the neurons, yeah, and we could feel it cause pain. And if you left it unchecked, a couple of days later, you'd see this red splotch, on your nose, and you knew, oh shoot, I've got a zit. And a few days later, you would have this white head pimple that would form. Well, in the arteries, the same process begins. We don't feel them, even though we have nerves in our arteries. They're part of the parasympathetic nervous system, so we don't feel them. But the process is almost identical. So that inflammation starts left unchecked. It grows into an inflammatory condition, and we get the proliferation of foam cells and all kinds of necrotic material, and literally a white head pimple forms, usually away from the lumen initially, and then eventually into the lumen. And then over time, that's an entire new disease process now, once plaque has formed. But the plaque goes through stages, just like acne. It goes soft white head, and then becomes kind of a cottage cheese filled substance, and then finally ends in a calcified, like an acne cyst, where it is very unlikely to rupture. So anyway, that's what we're measuring. That was probably more than your audience wanted to know, but you can tell I hate what I do. I just get all excited about disease. But we're measuring the thickness of that wall, because thickness tells us, A, how much inflammation is existent, and then two, we can actually see atherosclerotic plaque, which is predictive of events. And why do we use the neck? Well, the neck, because of the curvature of my neck, I can get to about 300 degrees of circumferentiality, right? So this vessel is a round vessel, you can imagine. And because it sits here in the neck, I can move the transducer around, and I can get almost 300 degrees of circumferentiality. So that's why we use the carotids. The other reason is that this is the last mile. But by the time disease reaches here, you have it everywhere. And so it's a great place to kind of study how far progressed is the disease systemically. Anyway, that's probably more than you wanted to know, but
no, we'll come back and talk about that. But what I
Yeah.
want to highlight for the audience, and don't worry, we are super nerdy on this channel. You can go into as much depth about this
Oh, good.
pathophysiology statistics as you want. They are
Awesome.
dying for it. But most patients say, well, I had a carotid ultrasound and it was fine.
Yeah.
So what is the distinction
Oh,
between what
that's
they're
right.
getting at
Yeah.
their doctor's office,
I
what
failed to answer the second
average
half.
person is calling a CIMT, and what you from
Yeah.
CardioRisk are really providing?
Yeah, so I forgot to answer the second half of your question, Lily. I do that. That's the professor.
That's okay. We'll get there.
Yeah. So the test that you probably use this in your office since you came out of medical, well, even while you're in medical school, right?
Sure.
Every test that we do in the cardiology office is to tell us one thing, essentially, and that is, can I do what I'm trained to do, which is do an invasive procedure, run a catheter through your leg or your clavicle, or do some kind of invasive procedure. That's what cardiologists are trained to do. And believe me, we need them. There's not a diminished need for them. But every test that they look, including the carotid ultrasound that we do in cardiology, called the duplex exam usually. And it's called duplex because it's two technologies. It's carotid Doppler, which is it measures movement. In this case, it's the movement of the blood flowing through the artery. And then B-mode ultrasounds, we look at the physical grayscale, if you wanted. Brightness mode is what B stands for. So we're looking at using those two technologies in duplex to tell us how good the flow is. Now, why is that significant? Because in cardiology, in order to ethically be able to do an invasive procedure, I have to answer one of two things. Either A, you have a blockage, a physical blockage to blood flow that is at or above 70%, or B, you're symptomatic. Absent one of those two criteria, I can't really ethically, because if I run a catheter in your leg, right, I'm introducing new risk, and we want the benefits of a procedure to outweigh the risk. So 70% is an appropriate cutoff. So the duplex, when you hear a carotid ultrasound, I would tell you most of the time what people mean is they did a flow study. And perfectly appropriate, absolutely worthless as a preventative test. In fact, the American College of Cardiology, the American Academy of Family Physicians, virtually every governing body that provides guidance to physicians has said, please don't use this as a preventative test. Why? Because imagine what the average patient does when they get a test result, they're holding it in their hand from their cardiologist, and it says normal. And by the way, if you are less than 70% blocked, it's going to say normal. So the average patient takes that test, walks it into their family physician and says, I don't need to take your stupid statin or drug. I don't need to do any of that. My cardiologist says I'm normal. Well, that's not really true, because normal in cardiology speak means I can't operate. That's all it means. Normal does not mean your arteries are normal by any stretch of the imagination. So that's carotid duplex. That's a flow study. Very important you understand the difference between that and an IMT. And then I will get to CardioRisk IMT, which is a level difference. So CIMT came out, as we said, in 1986, is the first time it was published. And it measures the thickness of the wall. So it's not looking at flow at all. We don't even look at blood flow. We completely ignore it. We're looking at the wall of the artery where this disease begins. Why? Because we can see the disease earlier. And by looking at the disease earlier, we get insights. Hopefully we can treat earlier and we can prevent. That's the theory behind it. Just like cancer, the earlier we find it, the better chance we have of treating. And certainly as it relates to cardiovascular disease, the earlier we find disease, the better chance we have of treating it medically, not surgically. Not that there's anything wrong with a surgical intervention, but
Oh, there is. There
we're
totally
in the business. Well, it has risks, right? So yeah, so that's what carotid IMT is, and you can go online and find half hour, or I think I found a half-hour video on how to do an IMT. Unfortunately, that's probably, those IMTs are not worth the paper they're written on. I'll defend that. It's in 2019, the standards body came out and said, yeah, it's not worth the paper it's written on. Like, they basically took IMT out of the recommendations because there was so much so many problems with reproducibility. They had to solve the problem. Well, we now I'm going to move into the third class that
Yeah,
that you
because
brought up.
I get up at meetings and I say, I do CIMT, and I have other physicians stand up and say, the American College of Cardiology says, don't do this.
Yeah.
And they say, if you see carotid plaque, then you can treat it as plaque, but like, we don't recommend CIMT.
Yeah.
So
Yeah,
how is
and
CardioRisk different?
I'm, by the way, I'm in agreement with those, believe it or not. I'm not here to dismiss those, because remember that they're talking about common carotid only, and they specifically have a problem with reproducibility. We solved that in 2005. We published our first reproducibility study was done in 2005. And the difference, this is what puts us in a different box. And there are several things, but most prominent is we have solved the reproducibility problem. Since 2005, every technologist that administers our test, so if it has the name CardioRisk on your report, that means that the technologist who acquired the images had to undergo and pass a double-blind performance-based certification. And Dr. Johnston, I'll just ask you, in all of your medical training, because it's 4 years of medicine and then 9 years of postgraduate education, a lot of freaking education there.
Yep.
Did you ever have to undergo a double-blind performance certification?
I did not. Yours is the only one.
Yeah. So in medical school, we have the saying, and I laugh about it. It's really not funny, but it's watch one, do one, teach one. And that's how we learned. That's how we were trained. And it's not that there's anything inherently wrong with it. Thank God the hospitals have standards, right? Where they require you to do, I think it's 250 catheter runs before you can do one on your own, or each hospital has their own standards. But there's nowhere in medicine that I'm aware of that requires you to undergo a double-blind performance-based certification. In any ultrasound school in this country or abroad that we found, there's no place where they are required to demonstrate proficiency in the methodology. They pass a multiple choice test, pass their boards. Isn't that what your your test was on your boards?
I also had to do an oral board exam, so I had to be interviewed, and they asked me questions, but I didn't have to actually do an operation or even talk about my cases, or much less have somebody watch me, or like a video that was blinded where they didn't know who I was, and judge my performance that way.
And if you thought about that at any sensible level, you'd go, "Oh my gosh." Anyway, I'm not gonna attack our medical system. We have the best sick care system in the world. There is no place in the world you'd rather go and be treated if you're sick. If you have a problem, then here in the US of A. But we're 54th of industrialized countries for prevention and wellness. 54th. Cuba has a better prevention center than we do. Like, that's an embarrassment to our system. And it's because somebody made the decision, probably some MBA, I have one so I can pick fun at us, made a decision in a corner office that it wasn't cost effective to do prevention and wellness. Well, I would argue with that, because all of the cost projections were based on 18-month studies. Yeah, I'll grant you, in 18 months, it's probably not cost effective. But over 10 years, it's really dang cost effective. Anyway, we're going down a different hole. So CardioRisk IMT, the key difference is, one, every technologist that works for us or doesn't work for us, because we have independent licensees like Dr. Johnston that undergo the certification of their own volition, but every one of them underwent and successfully passed a double-blind performance-based certification. And let me talk about that certification a little bit. To pass their standard deviation, again, hopefully we're talking to fellow nerds here. The standard deviation, that's if you do a bell curve, the mean, the standard deviation is going to be 0.023 millimeters. That's a quarter of the size of a hair on your head. What that means is the standard deviation between Dr. Johnson and I performing the same test on the same day on the same patient cannot be above 0.023 millimeters. Now, I would challenge your audience and any physician that wants to look at this. You go and look in all of the literature and you tell me, and please send it, Todd@cardiorisk.com. Send me an email and you tell me if you find anywhere in any genre of medicine a standard deviation that is tighter than that. We're very, very proud of it. It separates us from anybody in the marketplace, and it solves the number one problem that the standard creators have with this technology. Okay, so that's one, the reproducibility. By the way, the takeaway, Dr. Johnson, is that so there is a mathematical rule that says for statistical significance, some of your readers have read, well, it said that it was statistically significant. What that means is that the two standard deviations, that is the definition of statistical significance. So in our world, statistical significance is 0.05 millimeters, plus or minus 0.05 millimeters. That's half the size of a hair on your head, roughly. What that means is a change year over year or month over month, like over any time frame, if that measurement that we took changes by more than plus or minus 0.05 millimeters, you can be 95% certain that's a real change. That's not an error in the difference between Dr. Johnson and I administering the test. That is a change. Now, if it's below that, we would say it's statistically unchanged. Okay, so that's the reason reproducibility matters. Now, the second thing that CardioRisk would add to the equation is, I don't think anybody has a database anywhere close to the number of individual measurements, IMT measurements that we have. Over 250 million, we stopped counting at 250 million, and I think that was 10 years ago. It's just too many to count, but it's a lot of measurements. And what that gives us is a standardized protocol that is unchanged from 2005, reproducibility so we can track it over time, and then this large database that hopefully someday we'll publish from, that we can see these changes over time. And did I leave anything out, Dr. Johnson? Probably many
So
things.
I think, when I get a carotid duplex from the local cardiologist and somebody has one final image with a button on their ultrasound machine that measured IMT, right?
Yeah,
It's a one measurement. So talk a little bit about the protocol, what that 300 degrees of access to the artery
yeah,
allows us to do, and
yeah,
why the precision and reproducibility of the
yeah.
CardioRisk IMT is as high as it is.
Yeah, thank you. And that was, my brain doesn't work like it used to. I'm a little slower. But that would have been the fourth thing, is that our protocol matters. So a CardioRisk IMT is not just a common carotid IMT, and it's not just a plaque assessment. We interrogate the common carotid, the bifurcation, which is where this arterial segment separates into an internal and external. The internal feeds the brain with blood and oxygen, and the external carotid feeds the face with blood and oxygen, right? So our protocol is we interrogate the bifurcation of the common carotid, and then I would say the proximal end, the proximal 1 centimeter-ish of the internal carotid. Why is that important? Because this disease is uneven. And although it tends to present in the bifurcation more often than anywhere else, by interrogating common bifurcation internal bilaterally, meaning both sides, we have a much higher probability. Now, this is important because when you look at the guidelines, even back when they went from 2000, the American Heart Association gave us a stunning recommendation. We should do IMT on everybody. Essentially, I'm overstating it. But by the time 2013 rolls around, they completely moved away, gave us a class 3, which is like saying, this doesn't work.
Yeah, don't
And
do
they
it.
were right, by the way. They were right because the criteria that they looked at was common carotid IMT only, not even plaque assessment. Right? So I'm in agreement. If you do common carotid, a single measurement, some of those protocols used, a single measurement, meaning we take about 600 measurements, 300 on the right side and 300 on the left, just under 300, right? But if you take one caliper measurement off of a single frame, anywhere in the common carotid, not defined even the location, I'm in agreement. It's worthless. You may as well not do it. I would give it a class 3 recommendation as well. Okay, just for the record, you can say the purveyor of CardioRisk Laboratories, CIMT, says it's worthless if that's your protocol, and I will stand behind that 100% of the time. What makes us different is we actually have some smart people here that said, wait a second, let's not just look at common carotid. And by the way, let's not just take a single measurement randomized somewhere in one of these carotids. Let's look at the direct angle. Let's look at an anterior angle. Let's look at a posterior angle. And let's take not one measurement. Let's take just under 100 measurements of each of those. And let's do it on the left and right side. And even the least nerdy person that's listening to this can understand that is significantly different than what was in these publications where they said it's a 3A recommendation, right? Second thing is we're not just interrogating the common carotid. We're also interrogating the bifurcation and the internal. So you're not just getting, I'm going to measure the IMT, which let me explain why IMT is less predictive of events than plaque. Plaque is what causes events, right? So
Right.
one of these pimples pops suddenly and spontaneously. And in a matter of seconds or minutes, you go from no blockage. And I want you to hear what I'm saying there. Meaning that if you went to your cardiologist 10 minutes before you have your event, you would pass with flying colors every test in my office. Why? Because you don't have blockage until you do. The lucky ones are that, 15%, 20% of those that are lucky enough to get symptomatic, they get enough blockage that, oh, I got some chest pain, right? Those are the lucky few. The large majority of the population that has a heart attack and stroke, their first sign or symptom was the heart attack or stroke. So let me restate that. This pimple state, they're just all over your body. They're just lurking there, causing no problems. They're not causing any interference with blood flow. It's not even a pebble in a brook, right? So what happens then is that pimple suddenly and spontaneously ruptures or erodes. And in a matter of seconds or minutes, a whole cascade of events works against us to a catastrophic ending, usually in some kind of an event. But let's be clear, we don't go around creating blood clots just randomly, thank God, right?
Thank God.
A blood clot is a response to an injury. We don't form scabs on our skin, another way to say that, just randomly, right? Everybody can understand that. You get a scab on your skin when you injure it, you scratch yourself, and then these you emit these enzymes that activate the platelets in the blood. The blood rushes to that injury and coagulates, and you get a scab. Well, the same thing happens internally, but a scab on the inside of your arteries, for heaven's sakes, that is not a good thing. But thank goodness we don't just go randomly creating scabs in our arteries. Those scabs are a response to an injury. In the case of heart attack or stroke, it's usually a ruptured lesion, usually. Okay, so I forgot where we went down this path, but it's really important that we're looking for those pimples because that's what causes events. And if we're not doing two things in our INT, looking for plaque and looking for thickness, the thickness, we care about that because that's a measure of inflammation. Inflammation predicts plaque formation predicts events. And so the CardioRisk INT, I think, is how we started this. It's measuring both things. It's not just an INT measurement. Well, let's be clear. INT is the intima media thickness. So plaque is also INT, just for the record. But it is, we will acknowledge that plaque is a separate disease process, and we're going to identify those lesions separately. But remember, we're interrogating direct angle, anterior, posterior, so we're getting about 300 degrees. And in that formation, using that protocol, I would argue that most of the modern literature would say, no, that is predictive. In fact, even the current recommendations, they don't say it explicitly, but I'll show you where it does say it. Anyway, so very exciting.
Yeah, so we've made the distinction between thickening, intimal medial thickening, and plaque. And then is all plaque the same risk for this pimple popping, or do we make a distinction between types of plaque?
Dr. Johnston, you thank you for all these softball questions.
We'll get to some hard ones later.
These are really important questions that don't get asked in the literature. Well, Dr. Osamu Handa, a colleague of mine in Japan, answered this 15 years or more ago. But no, these soft whitehead pimples are 11 times more dangerous in his study than are the calcified plaques. I would venture to guess, even though and you're a thoracic surgeon, so I would say that the calcified plaques cause more problems in your field of work than they do in prevention, right? Because first of all, you got to rotor-rooter through them. It's a lot harder to do that calcified plaque. But in terms of their risk of rupture, a much lower risk, the calcified plaque. So in fact, I would go so far as to say that a calcified plaque is a healed plaque. It's in the final stage. It has almost no, in fact, I can't find in literature where calcified plaques rupture or erode. If you find it, again, say, I'm always on the lookout for new information, but I have not seen direct evidence of that. Usually when they allude to it, it's there's other good explanations.
But patients are confused, right? Because a high calcium score, which only images calcified plaque, does predict events. So make it make sense.
Well, and listen, I am a huge fan of coronary calcium score, so you'll never get me to degrade that technology. But all technologies have their strengths and their weaknesses, and we should acknowledge them freely. Like we can't be embarrassed about our favorite technology. All technologies, and I mean all, have strengths and weaknesses. So the coronary calcium score, to your point, as the name is derived, coronary calcium score, it sees calcified plaque, it doesn't see the soft plaque, which is why in the most recent guidelines, I think they're just out this year, right? Correct me if I'm wrong. As high as 40% of people with a 0 coronary calcium score went on to have events. Why is that? It's not that coronary calcium score is a bad technology at all. what it's saying is let's identify what it is and what it is not. Coronary calcium score is CT technology for my chest, and it's going to see the calcified plaque. Now, with new AI, some of those are getting creative. I think there's still reproducibility problems with that, but I love the fact that AI can spline these arteries in a long line, and it can see with a better degree of accuracy some soft, heterogeneous and calcified plaque. But in general, when we talk about coronary CAC, the calcium score, we're generally talking about calcified plaque only. And what does that mean? Well, if I take a statin, the number one foundational treatment for bad lipids, what that's going to do, ironically, is increase the calcified store. This is right in the guidelines, for heaven's sakes. So you can go read the guidelines. It says it right in black and white, in plain English. That somebody who is healing from this disease, their plaque is going to be more calcified. And I would argue that's one of the key benefits of a statin, is not so much what it does to your cholesterol score, but I think it's actually changing the plaque morphology and moves it from the soft echolucent plaque, which is extremely vulnerable to rupture, 11 times more dangerous, to a more calcified, almost no chance that's going to rupture on you.
So when I have my patients get CIMTs, when I do them, the CardioRisk report comes back with echogenic plaque, heterogeneous plaque, or soft plaque. And some of my patients are like, well, how useful is that when I can go get a CCTA or a CT angiogram of my coronaries and get this really cool AI overlay that has low attenuation, ultra low attenuation, like down to, tens of Hounsfield units, and like this color coded thing. Where are we with getting a little more granular from ultrasound in terms of plaque characterization? And is it even necessary?
Yeah, it's a great question. The answer is we don't know in terms of what's been published in literature. What we know is in these kind of broad segments that these three categories are what's seen in literature. But I would tell you, AI is wonderful. Don't get me wrong. I love the clearly, that there's a couple of vendors out there now doing AI. I love that clarification that it can add. We've been using AI for 35 years, by the way, to differentiate calcified from soft plaque. So don't get overly enamored with this technology. It is important. I think the reproducibility is most important. So what does that mean? Being able to differentiate over time a soft plaque from an echogenic plaque is extremely important for its ramifications towards risk of
And
event.
echogenic, for the audience, means calcified, right?
Calcified, yeah. Yes, thanks. And so absolutely, that differentiation is important. We use and have used for 25 years now a 100-point densitometric scale. What does that mean? So imagine that an artery is on our screen, right? You probably have pictures of an artery. And I outline this plaque on there with my outliner. And the system, the AI, goes in and says, okay, each pixel in that area has a densitometric measure scale 0 to 100. What does densitometric mean? Where 0 is white and 100 is black. It might be the reverse of that. I don't remember anymore. But each of them would get a score from 0 to 100. And then the software will then automate that what's the average of that score within the area that was outlined, right? So again, we've been using that for 25 years, and it's strong. It's important in terms of what it tells a provider, how aggressive to get with therapy. It has weaknesses, and I would tell you this is true of both the Clearly technology and of our technology. Why? Okay, let's talk ultrasound. When you have a plaque laid out longitudinally, a very dense echogenic plaque, a very calcified plaque, is so dense that the sound waves can't penetrate, and it casts what's known as an echogenic shadow. It's literally a shadow because the sound waves couldn't get through.
Right.
Well, that shadow, guess what color it is? Black. Same color as a soft plaque. So we have to be careful that to not overly rely on these technologies, and we don't. We use them to give us a back of the envelope, where are you? And then a human looks at that and says, yeah, but that's not soft. That's clearly echogenic because that's a shadow, right? You have to have humans that are capable of getting rid of the hallucinogenics that AI sometimes takes, for lack of a better word. But look, the answer to your question is, if you're my brother or sister or my mom and dad who have since passed, look, I want to test all your big vascular beds. I want to test your femorals. I want to look at your descending aorta. I want to look, I want to look at your coronary. I want to look at everything, because a study that came out, it's 26 years old now, but it was landmark. But if you have plaque of any size in any of this vasculature, your 10-year risk untreated, as best as this is, again, the best literature can give us, is at close to 40%. Well, what's the best that your Framingham risk score? I know we're beyond where Prevent. What's the best lifetime risk score that we get with all of the factors? How high do you go? About 20%? 10-year risk rate? Yeah. So the risk factor that your primary care doctor is using is going to get you a 20% 10-year risk rate on a good day. And those risk calculators are very flawed. We won't spend time on that today, but so plaque anywhere in your body doubles your risk for any risk calculator that your provider is going to have. So think about that for a second. Do I want to just check carotids? No. I want to look here. I want to look here. I want to look here. I want to look there. I would be looking everywhere. You are guilty until proven innocent is the way I look at it. And why do I want to know? Because Dr. Johnston can treat you differently if she knows you have plaque. Now, if you don't, that's great. I still am going to treat you as suspicious for plaque, and until I can definitively prove it. But please don't feel like it's one or the other, because they tell it. A coronary is a great scan. I don't want to say anything here that would keep them from doing that. If you got the money to go do it, please do it, but do it once. Let me just add this: 1,000 chest X-rays of radiation. You don't need to be repeating that. That's the one thing I would tell you, is go get it for sure. Everybody should have it after 50, and I think the new recommendations say 40 for men and 45 for women. But go get your coronary calcium score. I think it's a great technology.
But so here's another question I get often. Yeah. What are the chances that your coronary calcium score is positive if your CIMT from CardioRisk is negative for plaque, and call it a normal or younger than expected arterial age?
It happens, and it happens with greater, not so much in literature, it doesn't have much, it's less than 1%, but I would tell you, just think about what we know about the disease. I would expect to find it here more. This is the last mile. And so the way to think about it is, it should show here that not calcified, though. That's the caveat. The coronary calcification is a slower process. So we should see disease here, non-calcified plaque here, before we see calcified plaque here. But just disease process, you are going to have disease here in these bigger vessels. They form in the big vessels first. So this is the last mile. So that shouldn't bother you if my coronary calcium score says I got disease here and I didn't see it here. Don't be alarmed by that. The reason we do multiple vascular beds is just for that. These are screens. They're designed to rule things out. The primary reason for doing an IMT in that case, because people say, why would I even get an IMT if my coronary calcium score says I had disease? One primary reason. You can use IMT to track progression over time. You cannot use coronary calcium score to do that, for two reasons. The amount of radiation is excessive, not justified. Two, what am I looking for? Because the treatment, your calcium score is going to go up. So, am I getting better?
Well, both times, right? Either your disease progresses, which means you have more total plaque, and your calcium score goes up, which is why rising calcium score is in fact associated with increased events. But also, if we stabilize your existing plaque, your total plaque burden is the same, but more it's calcified. Well, then your calcium score goes up, and I don't know which it is.
Yeah. So those two reasons. Please, if you hear nothing else, go get your coronary calcium score, especially if you're over 40. But don't rely on that alone. for the two things we said. It doesn't see the soft plaque. And even if you use the Clearly technology, which is wonderful technology, remember that you're not going to use it to track efficacy of treatment. You want to know if Dr. Johnston's treatment is working, don't you? I mean, I would, right? We spend $2,500 a year on a statin or some kind of therapy. I want to know that it's working. And IMT, the study from Willett, I don't know if you saw that at all. Huge 119 meta-analysis shows that we can use it to monitor efficacy of treatment. And so it's important. We're going to use IMT as a better monitoring tool because it's just ultrasound. There is no radiation. And we can monitor more effectively what's going on, what effect is my treatment having on the arterials.
And so what should we be looking for if treatment is successful?
Yeah, that's a great question, and that is the right question. And understand, let me disclaim something here. Not all of this is in published literature, right? So I'm now putting on my hat as the chief medical officer with over 250 million measurements, right? So admittingly, I have not had time to publish and probably won't. When we can hire 6 or 7 more PhDs to come to work for us, they can do the publications. But
it needs to come out, Dr. Eldredge. We need
yeah,
the data so badly.
It does. But here's what I will tell you. Definitively, the data is there, and you're just going to have to trust me on that. When we treat disease, 2 things will happen. We will see the amount of inflammation, and I am making a bold statement here when I say the IMT, particularly if it reaches the average CCA mean, that's a metric on our report, exceeds 0.73 millimeters. That is a direct measure of inflammation. Remember that in the China study, we had Chinese field workers all the way up to 80 years of age with arteries at 0.50 millimeters. So that's as close as we can come to a healthy artery. In toddler studies in the U.S., I think we see it around 0.4 millimeters. But why argue? I mean, we're talking about a hair difference between those two. So anything above 0.5 is starting to get this disease process. We don't call it disease or inflammation until it reaches 0.73 millimeters for a reason. That's supported in literature, the atherosclerosis results in community study, and many others I could cite. At 0.73, I will tell you, in the case of the CardioRisk report, it is a direct measure of inflammation. No question in my mind about that. That's what we're measuring. And with treatment, again, with 100% certainty, we will see that measurement go down. The exception is there's a distal thickening in age, mostly over 80-year-olds, which I'm not sure, what the utility is. We just don't have good data over 80. There are conditions that are not directly related to arterial inflammation, just distal thickening and stuff, but we don't need to go into those exceptions. I would tell you, if you are between the ages of 5 years of age and 80 years of age, IMT, especially once it reaches 0.73 or higher on the average CCA mean, it is a direct measure of inflammation. So what does treatment do? What should it do? We should see a reduction. What do I mean by reduction? Again, using the coefficients of variability that we talked about earlier in this program, a standard deviation at CardioRisk, if you're a certified technologist to acquire those images in our protocol, your standard deviation is not going to be higher than 0.23 millimeters. What that means is if on your year-over-year report, you see a change in that average CCA mean or the average CCA max region, because they're both saying different things, a change in either area of greater than plus or minus 0.05 millimeters, we can be 95% certain that's a real change. That's not an error of the method. That's what we're looking for. Over time, I want to see a change of greater than plus or minus 0.05 in the downward direction, preferably.
What about rate of change? I mean, how long does it take to resolve the arterial inflammation? Should I be asking patients to reverse that in a year? Is 2 years reasonable? Like if I start an intervention and get a scan at time 0, when do I expect to see it change, especially if their, inflammation or disease burden is pretty high?
It's interesting. This is the first thing that we're querying in our database, and let me talk about the confounders, things that confuse the data, that why we can't answer this, why I haven't published already on this. The things that I can't look at, right? I don't know, did you take your drug or not? Are you getting your sleep or not? Are you getting your exercise or not? Did you stop smoking or not? You can tell me, you can tell Dr. Johnston, but it doesn't make it in my database. What I have are the changes. What I don't have, and there's no litmus honesty test that tells me, did you really take your medicine at night or did you skip it for a week? And so all of these things you can appreciate go in to confound the data. What I will tell you with near complete certainty, Dr. Johnston, is that the change in the arterial wall is the honesty test. It is the litmus test. Now, in terms of how long does it take, we just don't have great data. We have plenty of sources that say it can change in as little as 3 months. We have like multiple data points. And so, but we don't have a mean time to change except as it relates to plaque, and I'll jump to that in a second. Some people's biology, either they're lying to us and they're not really taking their medicine, or their biology is just different, and either could be the answer. Some of them take years to see a biological change in the arterial wall. What I will tell you is the measurement doesn't change. I mean, the measurement is what we need to go to, even over blood biomarkers, to tell us because why do I measure blood? I measure blood to say what's happening in my biology. Why do I care? Because the biology changes what's in the arterial wall. The arterial wall is the definitive, in my opinion. I may have a little bit of bias there. The second thing we're going to look for is the change. If you have plaque, we're going to look for change in plaque morphology, and we do have data on that. The mean time is a 3 to 5 year window between morphologies. So soft to heterogeneous is going to be a 3 to 5 year window. Heterogeneous to echogenic is a 3 to 5 year window. And that was an easier question to ask. I won't go into the details of that, but you can probably follow me on that, why that was an easier question to ask. Because if you see change in the arterial wall, we had better data to support those changes. But remember, that's the mean of 3 to 5 years. And anytime we talk about means, the patient that's sitting in front of you is an N of 1. They don't care what the mean is. And so what that means is that very literally, some people would change in a year, and some people would, that could be 10 or 12 years. The mean is 3 to 5 years. So please don't be discouraged if you're taking longer than that and you really are following your physician's advice. What I would tell you, though, as it relates to inflammation, if you're not seeing a change inside that year window, we haven't solved the problem. I will tell you that with no reservation. We have not solved the problem. And remember that there's over 250 known contributors to the disease. So don't be discouraged that we're pulling levers on 9 or 10 of them or 12 of them. There's 250. And I would tell you that if you're not responding to treatment in the arterial wall, you're not responding, then there's something else going on that we haven't solved. We have to keep opening the kimono wider and wider until we figure out what is causing this arterial inflammation condition.
So let me give you a couple of related scenarios that come up pretty frequently for my patients. The first is somebody who gets an initial CIMT exam from me, and it comes back that they have plaque, but their IMT is younger than expected for age. The second is a patient who came to me for another exam. So I did his first exam. His IMT was, we'll call it 0.75, and he had 4 millimeters worth of plaque burden. And I scanned him a year later, and his plaque burden was 4.2 millimeters, but the IMT was now, 0.72. Help us figure out where this discordance
let me
comes
talk
from.
about the first one because it's easier.
Okay.
So let me restate it, make sure I got the question right. The person has plaque but no inflammation.
Yes.
Yeah, that's an easy one. What we know is that is a patient that got better with or without your intervention. They had an intervention. That's the only possible answer. We know in literature that no exceptions that I'm aware of where plaque can form without inflammation. If you find it, I want to, because you'll contribute to my education. In every study that I can see, inflammation necessarily precedes plaque. And so when we have plaque and no inflammation, there's only one possible answer, and that is that inflammation went away because they had to have had inflammation to create the plaque at some point in their life. The fact that they no longer have inflammation means one thing, and that is something improved. I can't tell you what improved, but I can tell you with no question, no reservation, something improved. Now, that doesn't take them out of the woods because they still have atherosclerosis, right? They still have plaque. So you're not going to take them in put them in the all green light category. They're still at risk, even though we give them two thumbs up. It's very encouraging that there's no marked inflammation. You're still going to keep aware as a provider. Hopefully, your doctor's going to keep a wary eye on you because you still have atherosclerosis, and so every year we're going to monitor that like a hawk. But overall, that is a profile of somebody who is getting better. It's a good news. Pat yourself on the back. Keep up the good work, and keep looking for other markers of inflammation and disease.
Okay.
Did that answer the question?
Yeah, that's the first part. Now the second part, which is a little harder.
Yes, and maybe rephrase or say that again.
Yeah. So this is a patient that I scanned 1 year later. So on his first scan, I think I said he had 4 millimeters of total plaque burden, and his IMT was 0.75. And then I scanned him a year later, and it seemed like the plaque burden went up a little to 4.2 millimeters of total plaque burden, but the IMT was stable or improved and went to 0.73 or 0.72.
Yeah, that's a great question. I get those a lot. In fact, I get them so often that you probably are not. We need to update you. We have created another provider certification. It's free of charge on how to interpret our results because we were getting questions like this so often, and I realized that that's my fault that we haven't clarified this. We strongly recommend in this certification program that you do not use plaque size as a longitudinal monitoring. It's the most important value on our report, but it is not a useful monitoring tool. Let me tell you why. The coefficients of variability, the standard deviation for plaque is 10 times what it is for the average CCME. What does that mean? It means that, and let me tell you why. Plaque, the reason it's down in the comment section is because it doesn't equate directly to any of the literature. It's a single caliper measurement on a single frame. What does that mean? So Dr. Johnston's giving us an image, and from that image, our readers are putting a single caliper on the thickest area of interest on that image. Now, if she moves her transducer 5 degrees from 1 year to the next, we can have a 20% difference in the measurement because these plaques are 3-dimensional, right? And so if this is the mountain peak of the pimple, and I measure here 1 year and here the next year, there's variability there we can't control, which is why we don't recommend using plaque size as a primary tool. Now, plaque echogenicity, very reproducible. Plaque, no plaque, very reproducible. I can go into those if you have questions later, but plaque size as a rule, even plaque burden from 4.1 to 4.2, that's not even or 4 to 4.2, it's not even statistically significant. I would tell you, if you ask me privately, I'd say that's statistically unchanged. So
that's what I told his cardiologist, so I feel pretty good about that. But I wanted to hear from you and make sure I was right.
And we disclose it, like we're not ashamed of it. Look, there's no other lab but ours that even publishes their coefficients of variability on plaque, because they know that's kind of an iffy. The size of plaque is very, very tough. And Dr. David Spence, who's since passed away, a colleague up in Canada, great guy. We did a lot of research on 3D, and I'm personally of the current belief that 3D, as it relates to the neck, is still the physics of that are, I think, just statistically invalid. I'm not sure that we're there yet. I like the idea of plaque volume, and I think in a transverse, maybe we don't need to go into that, but I think we'll continue to research that and try and find better ways to identify plaque volume. But today, the 2D imaging, single caliper, or we actually measure the entire plaque lesion, by the way. We let the software find the single thickest area of interest so that we reduce variability. But even with that, the standard deviation is 10 times what it is for the average CCME. So please don't, I just would say it's not wouldn't ignore it completely. I mean, you see a big change of 0.9 millimeters. That's where, you might have some reverse cholesterol transport going on there. Who am I to say? But I think in general, it's a bad look to use that. And it's my technology. Like I'm falling on my sword here, but I just think it's a bad idea to use that as the primary longitudinal tracking mechanism.
Got it. Thank you. So walk me through what happens after my images get to the CardioRisk lab, because I haven't
Yeah.
seen the backside of it. And I feel like
Oh, yeah.
some of it's machine done and some of it's actually like tech done. Like what happens to those pictures and how does that report get generated?
I would tell you it's all human, machine assisted, but it's all human. There's no test that leaves our laboratory that doesn't have a human touching it, looking at, placing their calories. So what happens is you upload them to a central repository. Those get into a workflow, and the workflow it's generally one of the other things we do to reduce variability is your images will always be assigned to the same reader. There's a primary and a secondary reader. So if a primary reader dies or gets run over by a bus and the secondary reader, we're trying to think through every possible, like how do we minimize, and even though intrasonographer variability is very low, one advantage you have is you're always doing it. So your variability to yourself is going to be even less than it is between you and I, even though the variability between the two of us is very minimal. We have published, not published, but we have the data. I mean, I can go back to your certification course and tell you exactly what our variability is, right? But when it goes to the backside, we also are making sure that that the same reader, to the extent possible, is looking at those images, and then with a standardized secondary reader, right? And so they bring it up in our software, which is a proprietary, black box software that's been validated by an FDA cleared and all that stuff. All that means is the software's been cleared by the FDA to say it does what we say it does, right? It's measuring the edges that we're trying to measure. The software automatically finds the interface, and so the imagine that we're a longitudinal image of the artery. The sonog or the reader clicks where they want to start, because as you know, that's part of our protocol. Part of our secret sauce is how and where to start each measurement. So the reader indicates with a click, a mouse click, this is where I want to start. The software AI draws the line for it. And then the reader can go in and change, because AI hallucinates some. It's not even ours. We use quantum machine learning, so it learns every time a reader makes a change. It says, "Oh, why did you make that?" It remembers that, so it's getting very good. But still, the reader has the ability to go change the measurements that were made by the machine. Once she validates, she clicks the save, and that segment is now saved. We move to the next image in the series. So that's I don't know if that's answering the exactly kind of what happens. On a collective, another thing that's happening that you probably don't see is there's a qualitative assessment on the batch of images. So you get graded on every batch of images. Why? Because the one thing that I can't control qualitatively is you. And when I say you, I mean the people that are acquiring images. We got thousands of those, and the only way I can control that, the biggest weakness in our methodology is operator dependence. That is true of any test, by the way, not just ours. And so the way we qualitatively control for that is we qualitatively look at every batch and we grade it. And if there's a batch that gets a lower grade, it automatically gets sent to it kind of moves up the ladder, escalated. Eventually it escalates to me, by the way. Less than 1% come to me, but I still spend the bulk of my time looking at images and doing what I would call QA/QC on batches of images that didn't quite meet our quality standards, or that there was some weird anomaly that we don't fit cleanly in our predefined protocol. And you get that. There's just anomalies that come up that are interesting, and you would love to account for every possible scenario. You just can't. So we put my 35 years of experience hat on, and less than 1% come to me. And we're very honest and candid. You've probably had my QA/QC responses before, haven't you?
I'm not sure.
Yeah,
Not
so
sure I've seen
so
one yet.
a QA QC can come in two forms. It can be driven by us, where the reader says, I need a second look of this, or I need this wasn't, I'm not comfortable putting our stamp on this. The other thing is a physician can say, hey, I got this report back and it doesn't jive with the blood biomarkers, and could you take a second look? And so you have the ability to send those up
Mm.
up the ladder, and we'll look at those. But they're very detailed. Anytime you do quality control, this is true not just of our test, but of any, you could go to a Ford manufacturing plant. Job number one is to do a root cause analysis. What really is going on here? What is the possible, if we're talking about variability, option A is, well, the artery changed, they got worse, or they got better, right? But option two is, was there an acquisition error? So I have to parse out the data and look at the depth that the images were taken and the angle that they were taken. We do a very in-depth analysis, step by step, to say, okay, I can't account for it based on the image acquisition. Okay, now let's look at readers. Did the readers get lazy? All of this are things that can happen, and not to scare the audience, but these are things we are looking for actively. And what I would say about this is, if you're getting IMT done from somebody that doesn't have a defined QA/QC process, I, I would just tell you, with all due respect, it's not worth the paper it's written on. And I don't look, I'm of the opinion that the tide lifts all boats, right? So I love the vendors out there doing IMT, sonographers that watched a video and stuff. I don't have any problems with them doing it, but I would tell you, if they don't know what their coefficients of variability are, if they don't have a defined protocol that specifically states how and where am I taking the measurements, how and where do I take the images, and they don't have a prescribed QA/QC process for every test, you really can't trust the data. And there is no question in my mind why the standards bodies back in 2013 says, yeah, we just don't think it works that much. Because you had 119 studies published, all of them using different protocols. My gosh, what did you expect to have happen? And so we do need to move towards a standard protocol at least. And I would argue you need to add with protocol a standard QA/QC, because absent of that, in a human intervention, a human derived test like this, where the coefficients of variability are so tight, you really have to watch it like a hawk. And when I say watch it like a hawk, I mean every coefficient of variability. I need to look at the person acquiring the image, the person reading the image, the process, the entire workflow has to be assessed. That was probably more than you wanted, and I went down a little rabbit hole. I do that.
Well, but here's the thing that I know about you that maybe the audience doesn't. You weren't always into ultrasound. This hasn't been your whole
Yeah.
career. There was a period of time where you did some other things, and I want you to
Oh,
maybe tell that story
yeah,
a little bit and
yeah,
help us understand how you became the guy that made
yeah,
QA/QC and a standard protocol the
yeah.
thing for CIMT.
The universe is interesting. I don't know if you get into frequencies and vibrations, but I started my career epidemiologically in pediatric vaccines, of all places. So I was a young buck, excited to save the world by vaccinating the world, and I like to think we made a difference. I spent 10 years doing that, and in that I ran Sanofi Pasteur, the pediatric business unit for Sanofi Pasteur. And our greatest achievement in that 10-year window was changing U.S. healthcare policy from oral polio to injectable polio. And wait for it, on the basis that we would save 8 lives a year. Now, I'm not diminishing those 8 lives. If you're one of them, and I'm now at the age I would have been one of those, if you're one of those 8 lives, you're very grateful for that change, right? But I couldn't tell you who the 8 people were. I could just tell you biostatistically we were saving 8 people.
Right.
And we had a huge celebration. I went home from that, looked myself in the mirror and said, what the Sam heck are we doing here, Todd? Like, that's a lot of school to save 8 people's lives, and I can't tell you who they are. it's led me down a path to doing what I'm doing now. It's when I started going back to medical conferences and CMEs and got introduced to the man who became my mentor, Dr. Gene Bond. You can look him up, GM Bond in the literature. His curriculum vitae is thicker than either of the books that I wrote. Like, curriculum vitae are just, abstracts. To pay for that, because by the time I went back and started studying this technology, I had a family and I had bills to pay. So and because of my experience running everything, I had learned at a very visceral level about ISO 9000 and some of these quality standards, and somehow found myself to pay the bill, to pay my way through working with Dr. Bond. I would go on these consulting gigs where I still make way more money doing that than I'll ever make doing what I'm doing. And I found myself, being asked to solve problems I knew nothing about. Like, I'm on a manufacturing line for Coke. When a Coke bottle is one of my favorite stories. I know less than nothing about, well, now I know a lot about how to bottle Coke. Anyway, they had flown me down and paid me a small fortune because I don't remember what the numbers were, but they had systematic failures. At certain number of cases, the Coke was exploding out of the cans, and they wanted me to solve it. I'm like, I remember thinking, geez, I got to give their money back. There's no way I'm going to solve this. I truly felt guilt, and yet, kids got to eat, and so I'm like, well, show me your plant, and they showed me how these cans of Coke were bottled, and they had a thing called a stamping plant. So they'd have sheets of aluminum come through, and this big machine would come out, bam, it would stamp out what you see as the lid with the tab and everything. Very, very cool process. I spent a day just kind of like a little kid, like, this is so cool, and this thing would stamp, and I am so desperate. I confess now, sorry, Coke Bottling Company, if you hear this podcast, I'm so sorry. I really didn't know what I was doing, but we did solve the problem. We start doing what epidemiologists do. We start counting everything, and we counted. Okay, how many till failure? Well, I'm going to use the number 30,000 cases, right? And at 27,000, they were getting failures, but they didn't change the tool die. Think about cutting cookies. How many cookies can you cut till your little plastic cookie cutter wears down and doesn't cut the cookies anymore? That's what we're talking about. And so, I don't know, well, how often do you change the tool? Oh, we change it at 30,000 routinely, right? Really, well, what would happen if we change it at 25? I'm making up the numbers, but you get it. And sure enough, problem solved, big fat check to take home, show my wife. And look, what that experience taught me while I was simultaneously studying the coefficients of variability in ultrasound is that QA/QC is the way that you solve the world's manufacturing problems, including in science and health. And the only way you can reliably do that is to use scientific methodology. What do I mean by that? We used power statistics to form our protocol. It was formed scientifically from the ground up to say, I had a data point that I knew was crucial. The ERIC atherosclerosis results in community study was out, and Gene Bond, my mentor, was the author of that for the ultrasound. And he was of the opinion that, well, Todd, ultrasound doesn't, we can't get that tight of a, we can't get our variability down. I'm like, what do you mean you can't get it down? It's math. It's a mathematical equation. And so we argued about that for 2 years. We argued about it. Let me be specific. The difference in the ERIC study of the cohort that had heart attacks and strokes and the group that did not have heart attacks and strokes was 0.08 millimeters, the thickness of one strand of hair. So Gene had reason to say, Todd, there's no way we can solve that. And I just put it into a math equation. It's power statistics, and we created our how many measurements do I need to make to get that, tighten that up. So we mathematically created our protocol without any lack of deference for somebody who passes it. If they follow the protocol, they're going to pass our certification. I'm not trying to minimize it. It's they're going to pass that part of it. The part that we haven't figured out a way around is the interrogation for plaque. If they miss a plaque, you remember, Dr. Johnston, if you miss a plaque, that's a death sentence on certification. I can't certify you. And unfortunately, the only failures we have are those that we teach the protocol, but if it's very easy, I don't have to tell you to miss a plaque that's this big. And so it's the single most vulnerable point on our protocol, and all I can tell our technologists doing our protocol is you have to be so careful and deliberate, and it is a point of vulnerability. I'll concede to it to anybody that asks, but we're very, very good at it. Notwithstanding that, it is a point of vulnerability. So I kind of went off again like I do, but my background, I have a very strong background in quality and manufacturing, and that really kind of those two worlds of background in pediatric vaccines and then this background in manufacturing and quality that I just kind of stumbled into. These two worlds collided perfectly at the right time where ultrasound was trying to solve this problem. And if you look in the literature, even today, that is really the biggest resistance that the scientific community has for this technology. They don't disagree that it's interesting and useful. Their problem with it is it's not been reproducible, when you look at the network of people doing it. And I would agree with that. I've offered to provide our protocol, the acquisition side. We're still going to maintain control of the reading, but Quest Lab's not going to give away they're always going to insist you send their blood to them too, right?
Sure. Yeah.
So, but yeah, I think it's still the single greatest problem with the technology, and yet I think we've solved it, and I think we've proven that we've solved it. We I couldn't even tell you how many data sets I have of certifications. It's way too many for me to remember or count. But every single group that comes through our training has to they have to pass this double-blind performance-based certification, or we won't let them scan for us. So,
do you think that there's an equivalent QA/QC problem for these AI CT-based tools right now?
yeah, again, without saying anything, because I have other hats that I wear, occasionally get brought in as a consultant. I would tell you it's a very real problem. I spent I don't know if you know Ford Brewer, another dear friend of mine. We co-wrote an international best-selling book, and anyway, if you talk to him, he would tell you that there was a very real reproducibility problem we have not solved yet. And the problem is the company in question was going through their IPO, and so it was a very hotly, like you don't want to bring red flags in that. And so I don't know what the answer is. I can tell you that it's important. And it's important, not just our technology, it's important on any technology. You know what the reproducibility is on blood, by the way? People think
it's dependent on the individual test, actually, but it's not what you would hope it is.
In the same lab, you can have a 9 to 11% variability, again, depending, not all tests, please don't hear that, but on individual blood tests. So don't think that just because it's blood and it's scientific that it's error free. All tests, I don't care, any test in the world measuring anything has a known variability. And knowing that variability and the coefficients of variability is important to understanding how useful the data is, and how to apply that data. And I think it's disappointing we don't get in medical school, we don't really get a lot of education on statistics at all. We learn very, very broad terms of the number needed to treat, and I'm not sure most in the class even understand some of those numbers completely. The positive effect, the negative predictive value, and the negative predictive value, positive predictive value. I would tell you that half the doctors I speak to can't really define that very clearly. They get an idea of what it's about, but and so I think we need to do a better. I think it's an important. If you're going to treat people, I think you have to know how to use the test that you're using to make clinical decisions.
Yeah, my fear is that there's an illusion of precision that's coming with these new AI overlay technologies.
Well,
And,
they're cool. I mean, let's be
they're
clear. They're
super
really,
cool.
really cool. Look, notwithstanding the variability that's there, I would still say they have a utility. Like I'm not gonna, I would never dismiss them. I would just say use them with a grain of salt, and they should be accretive. They should add to the value of the portfolio. But where I would push back on anybody is that, well, I got this, so I don't need anything else. I go, oh boy, that kind of mentality scares me. And I would say that's true of blood work. Bring me your LDLC. You want me to make a decision on that alone? Oh, hell no. No, we're looking for a broad array, and we can't cost justify opening the kimono wide on everybody. But with a few tests, and I think CIMT should be one of them, we can get insight into what's going on in here, and we can then justify, man, if I find plaque on you, now I can open that. I can justify spending a lot more money on testing because I got to find out, well, what's I can tell you you're pregnant, but I can't tell you who the father is, right? If we equated IMT to a arterial pregnancy test, so which comes from data, by the way. The CAFE's case study, IMT caught 98% of the heart attacks and strokes. That's better than a home pregnancy test. Now, probably overstating that, but I often refer to IMT as the pregnancy test of heart disease, and for good reason. But yeah, all we're going to do, I wouldn't want you to rely just on IMT either. I would put us in the same box. Use IMT. It's a good back of the envelope, good preventative screening test, and it's part of the broader array of tests. And if you find red light or red flag in your blood biomarkers, your coronary calcium score, your IMT, your ankle brachial index, like on any of them, if you get red flags, it ought to hopefully signal to a provider, hey, I need to step back and look and open that kimono a little wider, and maybe do more testing to find out what's going on. We don't have to do that level of testing on every single person that walks through the door. But once we know that you got a red flag, yeah, I think we gotta do a deeper dive.
So what's coming next for CardioRisk?
Well, we've completed. So one of the neat things that we completed. So when you went through, I don't remember, but I think it was a 3 or 4 week turnaround process, the biostatistic portion. Do you remember how long it took us to get your certification back to you? It was a lot.
Couple weeks at least.
Yeah, because it was a prolonged process of we go out to the University of Utah's biostatistics, and we were kind of at their mercy. I can calculate it, but you don't want to be certified because I signed off on it. That's
Right,
low.
blinded. We said blinded.
Yeah. So we sent it out, but we have developed a platform, a software platform that we actually put the data in blinded, and it cranks out the statistics. And then we send that to the University of Utah. So we still do third-party verification, but rather than have them calculate it, we've been doing the calculations for 25 years. We know what the calculations are, and we're getting a lot faster turnaround. Right now, it's less than a week. So that's huge.
Yeah, that's awesome. How many technologists and sonographers and people scanning for you do you currently have?
That is the most closely guarded secret in the company. So I won't say that on a public audience, but I can tell you we've trained well over 1,000 technologists, and it's global. We have people in every major continent sending images, and and the number of scans has gone up exponentially. That's a positive sign. We find that patients, this is a note to any provider that's watching this, patients are getting impatient with physicians that will not adopt new technologies like this. We have thousands of patients a month raising their hand saying, yeah, my doctor doesn't do this. Can you just do it for me? And asking us directly, in direct communication, would you please offer us the test? So look, I understand that, by the way, we didn't talk about the standards, but there's some exciting stuff in there. For me, like I'm looking and say, hey, this is positive, even though they didn't give us a lettered numbered recommendation, they got rid of the 3 class, got rid of that completely, and they backhanded several references. One is regards to children. I don't know if you saw that, but they specifically in the guidelines said, hey, IMT caught disease in children as young as 5 or 8 years old, which was from the Bogalusa study, I'm sure. But anyway, very, very exciting news. And what this tells me, Dr. Shapiro's on that board, and he's in the IMT camp. We have several people now. Bots is there. A lot of previous naysayers are in the CIMT camp. I fully expect that when I'm actually writing a paper in terms of what's new that is not meant to be published, but is an argument to the standards bodies to say, look, I'm on a page, I'm on board with you with these publications that you use to justify your position, but there's also this 119 publications that you ignored, and that's not fair. Like, these publications clearly state that IMT has a place. One of them, if Dr. Willett, if you're out there, just wonderful judge. Have you seen his article? I'll send it to you. It's
Please
fabulous.
Send it to me. I'll review it on the
it's
channel.
Fabulous. And there are researchers worldwide that are getting on board. And to the extent that the researchers use defined protocols and standards, and I really want to emphasize that, and that they have quality standards, I would tell you that the literature, it is going to say that what we've seen for the last 35 years, right? It's going to correlate to events. IMT is going to correlate to plaque formation. Plaque formation is going to correlate to events. So on a more loose scale, you can understand why IMT, if they say IMT alone, they're referring to just the common carotid measurements. And yeah, that I'll concede that's going to have a looser correlation, but don't ignore it. Because it absolutely correlates to plaque formation. It absolutely tells us something about disease process, and I think that's been ignored by the standards body so far. So,
yeah, one of the questions that came up when I showed my own IMT results on the channel were people asking about the standard population, right? For every CardioRisk report, there is that progression over time normed by age and gender.
yes.
Who are those people, and
Yeah.
how cautious do I need to be in interpreting for patients of a different ethnicity or, not of U.S. origin? Like, what is that population, and how careful do I need to be in interpretation?
Those are U.S. populations, which is why we use them, and it's the Canadians and Japanese and people in Southeast Asia that probably have a bigger qualm because they're all U.S. based. The atherosclerosis results in community study is the biggest normative data, but remember that all 4 of the studies or all 5 of the studies, excuse me, that we use for our histogram ignore one important population, and that's those that had events or died. And so we are understating risk. We're not overstating. And,
Okay.
and they should be, you do not want to be on that line. You want to be below it. If you're on the line, just trust me when I tell you that, because we don't have the people on there represented that died or succumbed from the disease, we're understating risk. So you want to be below that line. And
So that is a quote unquote healthy population to the best of our knowledge, right? No major comorbidities or what? Who is there?
It's the ERIC cohort. So you
cohort.
can look. Yeah, ERIC is the bulk of it because if you're 45 and up, it's which is the bulk of your patients, it's going to be the ERIC. Bogalusa was down, I think was the one down for kids. So by the way, the new standards, this 2020, or I think they're published or they're in print in 2026. I think it's 2025 standards, but I can't keep track of that. But there's on the section on pediatrics, right in their statement, it says that IMT found disease. So if you find disease in children, they ought to be screened earlier. And if we find disease, they need to be treated, spoken like any true lipidologist, I guess. But the point.
So mostly you're thinking about patients with either heterozygous or homozygous familial hypercholesterolemia or dysphagia.
So what I would say, because people ask me all the time, who's the appropriate candidates for this disease? And I would tell you, over 30, absolutely, you should get it at least once. Absolutely. If you're Amy Doneen, she would tell you, because we used to say, get it once. If you're all green, come out in 3 to 5 years. Amy had a coronary attack when I told her that. She's like, what are you telling people would you wait 3 to 5 years to do blood labs? And I'm like, God, you're right. No, we would never wait 3 to 5 years for blood labs. But 30 and older is appropriate. That I would tell you younger, if you're from Southeast Asia, if you're African American descent, or you have, this family history. Look, the Bogalusa Heart Study, with IMT, and IMT, let me specify, from 1990s technology, right? So not what we're dealing with today. We have much better imaging quality. Yes, you do not have to feel guilty about having a kid checked, for disease. I'm not going to advocate for every kid. I think I don't think you'll find a net number needed to treat is going to be effective there. But if you have a concern, if you're a parent and you have a concern because grandma or grandpa, whatever your reasons are, or you've got specifically familial hypercholesterolemia, I think getting an INT on them is absolutely rational, if nothing else, to get a baseline so we can measure sometime in the future to say what is the net effect of this dyslipidemia. So.
One of the qualms I have as a prevention person who has now a little bit of a broader reach than I used to is I have people who can't seem to get good access to a CardioRisk CIMT. And to which I say, again, let's use what we have available to us. If all we have is a CAC, then we'll start there and that's fine. Yeah. But I, like you, have become a real believer in the utility of this technology. And if we have time, I'll tell you a story toward the end that I think will really warm your heart. But for now, let me just ask, how do we help you and how do we help ourselves broaden the reach and the expanse of CardioRisk so that more people can get access to this?
So really glad you brought that up in the context of what else is new with CardioRisk. This was one of those things that kept me up at night, is we did not have, even though we'd certified many providers, they were doing it for just their practice, appropriately doing. But it kept me up at night, literally, because we know that we were not serving the population at large. So one thing that's changed in the last 2 years, this may take you off guard, and part of it is due to podcasts like yours. We're on like 100 podcasts, and so our phones were ringing off the hook with, "Hey, how do I get this?" And we had to solve for it. And we solved it like we do any QA/QC problem. Look, what's the root cause analysis? Why don't we? And we have solved it. Our guarantee. So Fort Brewer, a personal friend, and just has a huge following. I made a guarantee to him 3 years ago. I said, "Look, if you have somebody that sees us on your show, I will guarantee in writing they can get this test within 30 days, within a 2-hour drive." And we met that. Now, the exception is we couldn't say that Hawaii and Alaska, the continental US, and we're even better. We have multiple. So what does that mean? If your physician doesn't do this, what I would tell you is, if you're in Dr. Johnston's area, have her do it. She's certified, great. If you're outside of the area or you have your own primary care physician, I would talk to them in earnest. Show them our website. We'll give them chat. I will provide them. I didn't write a book to make money. And I've never made a dime. I could donate all the proceeds to the American Heart Association. I will give them the book. The only reason that's important is it gives chapter and verse of the science behind this technology. And we won't even ask the doctor, your provider, to read the whole thing. We'll bookmark it. Here, you got to read this little section here that will highlight the science behind this technology. So our first preference would be go to your provider, have them call us. I'm happy to sit on a call with them one-on-one, walk them through a very short slide deck that gives chapter and verse of why and how, and we'll make it stupid easy to do it in their office with one of our certified technologists. Yeah, that would be my first preference. But if you don't have a physician that's willing to do it, or they poo-pah the technology, or you just don't feel comfortable, I would tell you, go to cardiorisk.com. I try not. I'm a scientist, right? I'm not a sales guy. The only reason I give you the website is that is going to be your access point. And if you go to our website, it will show you hundreds of. You put in. I think all you have to do is say, "Here's my state or my city, my zip code," and it will populate with tests in your area in the next 30 to 60 days, and we'll get you handled. We will get you a test. And you might have to drive a couple hours because we're in the big cities. That's a logistics issue, right? But we will get you a test. And if you can't find one close to you, I would tell you, call us, because we'll set up an event for you. And because we know that if you want it, there's other people, you have friends and family, and we will literally set up an event for you. So I'm not trying to be promotional or salesy. I'm just saying this technology works, and we want to make sure every person in the United States of America anyway can get this. We're working on Canada and we're working on Mexico, but those are going to be, I can't solve that. I may not be able to solve it in my lifetime, but right now in this continental US, I can tell you we will get you a test. And in most places in Alaska even, so it's the big cities where Alaska is that's a huge place, right? But in the big cities, Anchorage and stuff, yeah, we'll get tests going up there as well. So I don't know if that answers your question.
Absolutely.
What
And
I would tell
I've started to see the pop-ups, and that's
you.
been
Yeah.
great to see. What is it going to take for us to get insurance to cover this?
Well, it's interesting to say insurance does cover this. That may meet with surprise. We've had a class 3 code for years, but let me explain something to you know this, but your listeners may not. We have a sick care system in America. What does that mean? It means you have to be sick, and the doctor has to prove that you're sick with what's called an ICD-10, a diagnostic code. You have to have a diagnosis to have anything covered. So think about that. The only 3 exceptions as it relates to prevention: pap smears, colonoscopies, breast exams that I'm aware of. And why? Because somebody in Congress died from one of those conditions, and they got hot and bothered when they found it was preventable, and they mandated by law that insurance companies cover those 3 tests. So you will not find an insurance company, they have to cover those 3 tests, but they're not mandated to cover IMT. Not that there haven't been any congressmen die from heart attack or stroke, for heaven's sakes. Apparently nobody's told them that there was a way to prevent them. But anyway, so let me get back to the test. There's 2 ICD-9 or two, excuse me, CPT
Yeah, there's a
codes.
CPT code, but the existence of a code does not mandate
Yeah.
that there's no RVs
Yeah,
associated with it.
So yeah, let me explain what that means. By the way, there was a study came out years ago, it's 10 years old now, that if a test was less than $400 billable, it's not worth Dr. Johnson's time to bill it. Because Dr. Johnson, your biller, here's what's going to happen. They're going to send for this is not just IMT, this is any test. They're going to reject it once. This is default. This is part of the workflow that all insurance companies use. They're going to reject it a second time. Statistically, the 4th time is the magic bullet. Dr. Johnson and her staff do not have, I shouldn't speak just for you, but your provider doesn't have time to keep billing 4 times to get reimbursed for a test, which, by the way, they're going to get $120 for, right? And they had this 4 times submit billing and extra documentation to get their $120. It's not worth the time that it takes. Having said that, it does have a CPT code, and I can tell you that it is covered. We have a guy in California that routinely he's figured out some magic formula that gets them all covered. But in general, I can't. It's against the law for me to give you an ICD-10 and here's the magic one that works. I can tell you if all you put on there in your diagnostic code is hypertension, it's going to be summarily rejected. Hypertension is the most overused ICD-10. We use it for everything. Yeah. But if you had something, let's say there was a diagnostic code that said something like narrowing of the arteries. Again, don't want to break the law, but I can tell you there are absolutely ICD-10s that will get that 93882 covered. Absolutely, because we see it nationwide. Is it worth the time investment to do so? I'd probably say no, and I would say even for a patient, if you're really, you're going to get $120. The cost of an IMT, even retail, is a night out on the town with drinks once a year. Buck up. I'm sorry I can't do it for less. But yeah. But we have to pay for the back end that we just described, and it's expensive. But I will tell you, it'll be worth it. So, yeah. I'm sorry that's not what you want to hear, but it is covered. It's just probably not worth the time to.
Well, yeah, I would say that's a carrier dependent phenomenon, right? So not every insurance will cover it. Medicare typically does not. And so it's again, from my standpoint, I basically tell patients, you are welcome to submit it for reimbursement, but I am not willing to attempt to bill your insurance when I don't know what will be covered or not. Again, with the price of it being as reasonable as I think it is,
Yeah.
relatively speaking, I kind of draw that line for folks. Yeah.
Can I just say one thing about that too? And not to diminish. Look, times are tough. I know that costs are going up for everybody, so I'm really not. I'm very, very sensitive to the cost of tests and all of the things doctors asking for. But listen, if you are going to decide your health care based on what some MBA in a corner office of an insurance company is going to authorize or not, you should just plan on dying at about the age of 76, and just do that. Because I don't mean to diminish our healthcare providers in any way. I'm just saying the system is stacked against prevention and wellness in this country. It just is. I mean, you can accept that or reject it, but I will tell you, if you really care about your health care, if you care about extending the quality and quantity of life, you're going to have to take ownership of it. And that means you're going to have to explore peptides and nutrition and some of these tests that are not going to be covered. If you're expecting your insurance company to give you a carte blanche, it's not going to happen. And by the way, even and especially when public health care comes, and it is going to come, it just is, even less so then. They're going to cover what is financially feasible to cover, which is not prevention and wellness in this country. And so, if you want to be well for longer, you're going to have to make a budget for it, and you're going to make decisions that are different than. I don't mean to call out a Kaiser or any network, but networks that's what they're built on. And by the way, Kaiser does a great job, better than most, at moving in that direction, but it's still a system. And the healthcare systems in this country are predominantly sick care systems.
And as you point out, I mean, these are fiduciary things based on a short time horizon. I think the average patient spends 3 years with any given insurance carrier. And so the calculation for what's cost effective for them is a 3-year time horizon. So detecting
Blue Cross,
atherosclerosis.
It's a much longer win. By the way,
that operates on decades, right?
I got a great analogy for that I want to throw in, just because your listeners may get a kick out of it. But I was meeting with Blue Cross Blue Shield executives. I won't say which one because that way it gets me off the hook. But they were telling me that their patients change on average 18 months. It was not 3 years; it was 18 months. And I said, so your economics are built around 18 months. This is the equivalent, by the way. What that means is, if we did a study, Lily and I did a study, and we looked at air travel from Los Angeles to New York. We're going to do a study. We're going to study 10,000 flights from New York, or from LA to New York. And we're going to measure efficacy of those flights at getting you to New York. And we stopped the study at an hour and a half into the flight. You know what our study would say? It would say air travel is 100% ineffective at getting passengers to New York City. That's what it would say. Can you imagine? That is what's happening in healthcare. We build studies, economics, the study of the economics of prevention and wellness based on 18 months, might be out to 3 years now. Big deal.
Yeah.
A 3-year window to show value of prevention and wellness is ludicrous. It is the absolute definition of insanity. And so to have a chance at 10 years, I can tell you, we absolutely show, we have data at 10 years, but nobody wants to use it. And I said, well, isn't the one of the other carriers, aren't they just sending their patients over the fence, and they're sick and you're sending them theirs, and you all end up having that's
right.
They do not see the insanity of their position.
Yeah, the rising tide would lift all ships that way.
Oh my gosh. Anyway, I just thought you'd like the aircraft analysis. I use that often because it cracks me up, but that's what we're doing in this country. So.
Yeah. Well, let me end on a positive note. I was at a meeting last weekend, and I offer CIMTs there. I ran into Dr. Brewer there. We had a nice chat.
Oh, how wonderful.
And a woman came up to me. I had scanned her at a different meeting about 6 months earlier, and she said, "Dr. Johnston, I think you saved my life." And
Wow.
I had, unfortunately, but fortunately, detected some plaque and an advanced arterial age in a relatively young woman who's undergone a huge transformation in her life. She has improved her nutrition and she's lost a bunch of excess fat and she's feeling as well as she has in many, many years. But we detected plaque, and she was traveling and she started getting some chest pain, and she took it seriously because she knew that there was some
Yeah.
likelihood that this was real. And she got checked out. She got an angiogram. She fortunately did not need a stent, but she also had coronary disease. And now she's gotten care and she's on a path that is going
Love it.
to lead her to a place of health, right? And it was such a powerful example of why you and I do what we do and why we feel so strongly in
Yeah.
bringing this to a place where I don't need, a minivan with a huge CT scanner in the back to like be scanning in the parking lot, right? I have my ultrasound, it fits in an overhead bin. I can go scan wherever, the universe takes me and try to
Yeah.
provide this for as many people as I can. And it's so gratifying to be able to help in that way. So thank you for allowing me to do
Wow.
that
Yeah.
and to scan for you guys.
Well, thank you, and that is why we do it. By the way, we bought a building so we could move all of the departments in one place. It didn't work, but we're close. But we have a bell, a cowbell, that we used to ring regularly, and we would ring it when we saved a life, but it was ringing to it, and that now it ring. We just had to stop that process. But we define saving a life as if we found somebody with plaque. And it is bad news, good news story, right? The bad news that they have disease, but so good. We have the literature would say we got decades to work on it. So if we
Right.
find it, that's a good news story. It's bad that you have it, but you were going to have it anyway. The fact that we found it gives us time, and so we don't ring the bell anymore. But everybody in our company celebrates the opportunity to extend quality and quantity of human life. And thank you for partnering with us in that venture. It's so important, and we're grateful to be involved in this endeavor.
Well, Todd, thank you so much for coming on today. I know we've taken quite a bit of your time.
Oh,
There
that's
are going to
good.
be a ton of questions. I hope that maybe you'll agree to come back for
I'd
a
love
part
to.
two
Yeah,
where we can get into everybody's questions. And I have some more
you
nitty gritty
bet.
questions about, CT angios and all that thing and all that stuff. But
Yeah, I'd love
this has
to.
been such a great conversation.
It's been fun. Thanks for having me. And yeah, please have me. I'm happy to do a follow-up anytime. So
We would
see ya.
love that. I will check in with your team about when we can get that scheduled. Until then, thank you so much.
Thanks, Lily.
I hope you guys learned as much about CIMT and plaque detection as I did. Thank you so much to Dr. Todd Eldredge for coming on. You guys will absolutely have a bunch of questions. We will do a round two with him as soon as those all roll in. Until next time, take really good care.